Welcome to the SASS support group meeting. Today we are sharing about blockages and constipation. Do you know the difference? As much as we are offering advice, this advice is based on the most common scenarios, and the information is compiled to empower you, the ostomate, to better understand and navigate your new normal. We will always advocate that you consult with your physician or your stoma nurse because they understand your unique set of circumstances better than we could. If you do need to find a stoma nurse, the South African Stomaltherapy Association, or SASA for short, have a list of registered stoma therapists on their website. Please contact www.stoma.co.za. Alternatively, contact SASS via WhatsApp on 066 261 0654 or on our website www.sasstomates.org.za.
Good evening and thanks, Lorato, and good evening to everybody. For those of you who don't know me, I'm Sister Dee. I'm the current president of the South African Stomaltherapy Association. I run a private practice, stomaltherapy practice in Cape Town, after some discussions with Faisal, we've agreed that we will provide some education to the SASS members based on questions and comments which pop up on the SASS WhatsApp group. With me this evening is Sister Jane Hoole, who is the current SASA treasurer and who has a private stomaltherapy practice in Johannesburg at the Donald Gordon Medical Center. And Jane is going to be presenting part of tonight's talk for us on constipation and blockages. So thank you, Jane, for joining us.
Good evening, everyone.
Okay. In discussion with Faisal, Faisal and I agreed that what we would do is do a little bit of the recap of last month's session before we speak specifically on constipation and blockages. For those members of SASS who did not attend last month's session. So to start off with, we wanted to remind you all that you are all unique and that you all are your own people, and that as ostomates, you, each and every one of you, should be treated and managed as individuals and not as a collective group of people. So in other words, not as a group who have colostomies or a group who have ileostomies or a group who have urostomies, because every single one of you is different in many ways. To start off with, not least of all through your disease process, the type of operation that you have, the type of stoma you have, and the ongoing treatment that you may be undergoing. So just a little bit, just to raise this, it's a concern that Jane and I have picked up a little bit on the WhatsApp group. We think it's a fantastic group, and you all give each other the most amazing emotional support and practical guidance with regards to day-to-day living and tips, for example, on bathing, swimming, traveling, hygiene, things that you've learned along the way that you are able to share with ostomates. But we are concerned about the medical advice that some patients are sharing with other patients. And we would like to caution you on doing this because you are all so unique, because you've all got different diagnoses, you've got different stomas, you've got, different comorbidities. Providing any form of medical advice, even if it is about suggesting to someone that they take a laxative, it could actually prove to be detrimental to your fellow ostomates. So we'd like to just caution you on that. I'm happy to have any further discussion regarding that if you so wish. So just to remind you that the gastrointestinal tract, which is also sometimes called the digestive system or the intestines or the bowels, some people refer to it as their gut or their stomach. The gastrointestinal tract actually starts at your mouth and it ends all the way down at your anus. So if we have a look at this diagram, your gastrointestinal tract starts at the mouth, followed by the esophagus. The esophagus feeds into the stomach. The stomach then feeds into lots and lots and lots of loops of small intestine, which then in turn feeds into the large intestine or the colon, which runs up the right, across the top, down the left, and then to your rectum, which is the reservoir that holds stool before you need to go to the toilet, and the anus, which is the passage that the stool passes through when you need to go to the toilet. And this gastrointestinal tract is one long continuous tube, which is hollow and is made up of different sections. Along that gastrointestinal tract, you get lots of different types of stomas. So you can get an ileostomy, which is made from the small intestine, and it could be right at the end of the small intestine, or it could be up near the top. And the differences there would pertain to the volume and the consistency of the stool that comes from those ileostomies. You might have a colostomy, but it might be a right-sided colostomy or a transverse colostomy or a left-sided or descending colostomy. And again, the management and of these different colostomies is all different for everybody. The stool consistencies are different, the structures are different. And every stoma looks different. And on this slide, you'll see photographs of current patients of both Jane's and myself. And these are the different shapes and sizes and constructions and placements of stomas on the abdomen. So there's no straightforward, if all stomas look like this one here, which I'm indicating now, then life would be really easy for you as the patient and for those of us who are stomal therapists or stoma care nurses. But the reality is that we're dealing with a whole host of different shapes, sizes, types, and placements on the abdomen. So every single one of you, again, will have a different looking stoma. As I mentioned earlier, as we move through the gastrointestinal tract, the poo or stool consistency is different. So the stool that starts at the top of the small intestine will be very, very watery. And as it starts to move along the small intestine, it will start gathering up a few bits. And by the time it gets to the end here, it's a little bit mushy. And then as it drops down into the colon, it slowly, slowly starts to thicken as it moves around and then becomes a more solid and formed stool. And this chart here describes the different stool consistencies that we see from different stomas, but also in different situations when patients might have diarrhea or you might be constipated. So, you know, even though you might have a left-sided colostomy and you expect your stool to be firm or solid, there are different reasons why the stool might not be. So it is where in the gastrointestinal tract the stoma is made, how much bowel has been removed or bypassed, whether you are having radiation or chemotherapy, or if you're on any other types of medications that can affect the stool consistency, whether there's a presence of infection. Your food and fluid intake can also affect the stool consistency, and whether you are moving and doing any exercise. So as I mentioned earlier, the stool consistency from the colostomy will depend on where in the colon the colostomy is situated. So if it's on the left side here, the stool is going to be fairly loose and mushy. And as the stool moves around and down, it should thicken up. But if you are having chemo or radiation, or you're on medication, or if a large portion of this part of your colon's been removed, well, then it could well be that you're going to have a loose, mushy stool from the left side that did colostomy as well. What to eat if you have a colostomy, as we discussed last month, the general rule is to eat anything and everything in moderation, to take in adequate fluids, continue any specific dietary requirements as instructed by your doctor or the dietitian. If you are on a diabetic diet, it's important that you follow that, or if you're on a low salt diet, that you follow that as well. Yes, there are some foods that can cause increased flatus or wind or farting into the bag, but that is for each individual person to identify for themselves what makes them more windy. Some foods can cause discomfort. Some foods can make the stool a bit looser. So you might have a left-sided colostomy with a nice firm stool, but if you eat a curry or a chili or something spicy, you might have a slightly looser stool the next day. But that's not a reason not to enjoy that curry or that chili. So, you know, it's when you have a stoma and on the front of your tummy, I think it's difficult not to assess all the time what your stool is looking like and what consistency it is. Whereas before, when it was dropping down into the loo, we didn't really take as much notice. When you have a colostomy, it is possible to become constipated with diarrhea, and we are going to discuss constipation in more detail this evening. So I'm going to hand over to Jane, who's going to talk about constipation, if you have a colostomy, and then we will move on to ileostomies and blockages.
Good evening, everyone. My name is Jane Houle, and as Dee pointed out earlier, I am a stomal therapist at the Bitston Gordon Medical Center, and it's lovely to be with you all this evening. And I just want to say how well I think you have all done and what a great group of people you are. So let's look at constipation. What is constipation and how is it defined? What does it mean to be constipated? So if you were to look up a definition, it would tell you that constipation occurs when bowel movements become less frequent and stools or poo become more difficult to pass. So every one of us, whether you have a colostomy or you don't have a colostomy, will know what it is to be constipated. It's uncomfortable. You are often bloated and passing winds and straining and stressing to pass the stool. So just because you have a colostomy does not mean that your stoma must pass stool every day. And that's something you need to really take on board, because as Dee mentioned earlier, when your stoma is on the front of your abdomen and you're it's in your face every day, one is going to be a lot more aware of what is happening compared to before, when you were going to the loo, and whether you passed a stool or not, it didn't really worry you. So it is not unusual to not pass stool every day, and everybody's different. Some people will pass stools 2 or 3 times a day. Other people will go to the loo, pass stools into their bag maybe every 3rd or 4th day. So important to remember is also the quality of the stool. So if you're passing a nice formed but mushy stool into the pouch every 3rd day, you're probably not constipated. And so there would be no need to worry. So what are the possible causes? The same causes that were appropriate before you had your surgery are often appropriate after your surgery. So a change in diet or routine, and every one of you who have maybe been very regular people, always got up in the morning at 6 o'clock, had a cup of tea or coffee, or glass of hot water and lemon, and then, you know, your tummy worked. If you change that routine for whatever reason, and it might be that you're going on holiday and you're having to get up earlier, and so your routine changes, that can create and cause your bowel to slow down and to try and then has to readjust to a new routine. Painkillers, like any kind of medication, painkillers, still pain, anti-inflammatories. Miprodol is a big contributor to being constipated, and you only need to take 2, and that would constipate you.
Yeah.
So an inadequate intake of fiber, so things like brown bread, fruit, fresh vegetables, they're really important elements in your diet. And we should try and eat from all the food groups every day. So for that person who has a colostomy, and as Dee alluded to earlier, there is no special diet. We encourage our people to eat from all the food groups exactly as they would like or as they did before. A very big contribution to constipation is an inadequate intake of fluid. And many people just don't drink enough water, and I am one of them. And I can spend an entire day seeing patients and working in my consulting rooms, and when I get home at night, sometimes it's not until I go to bed that I realize, in fact, that I haven't been to the toilet to pass urine. Now, that is a major contribution, not only to constipation, but other complications as well. And then lack of movement and exercise. So we really should all be walking and doing some exercise in the day. So those are the possible normal causes of constipation. But there may be other issues. So if you know that you haven't had a change in diet, your routine is not changed, you don't take painkillers, you definitely take enough water and other fluids, and you're definitely exercising, but there's been a change in your daily habit, it's never a good idea just to say, oh, well, I'm constipated and I'll do X, Y, Z. You need to bear in mind that you've all had operations. And as a consequence of operations, you will, all of you, have what we call adhesions. Now, adhesions are scar tissue which form inside of the abdomen. And the best way to describe an adhesion is to think about a bowl of wonderfully cooked al dente spaghetti. And when that al dente spaghetti has just been cooked, it's wonderful. You can twist it around, you can pull out a strip of spaghetti, you can slurp it into your mouth, and it's quite difficult, in fact, to break. But if you leave that bowl of spaghetti to get cold, all the starch and the gluten leaches out, and that bowl of spaghetti, which was once beautifully loose and you could pull strands of spaghetti out easily and twist it around your fork, is now all stuck together. And that's what adhesions do to your, into your organs once you have had an operation. So bear in mind, it could be an adhesion that is causing your constipation or your discomfort, the bloating and the pain. And then, of course, recurrence. So recurrence of disease is something always to bear in mind if all of the possible normal causes of constipation you have been able to negate. So can you be constipated and still pass poo? Yes, you can. And that's very often something that flummoxes people or puts them off the scent. Because if you become constipated, what will happen is that the loose stools far back in the bowel will start to push past the hard, thick stools that are not, dry stools that are not coming through. And then you get this runny poo. And so it can be a bit confusing. People say, are you constipated? And you say, no, I'm not constipated, I've got diarrhea. When in actual fact, you may very well be constipated and you've got what we call a bypass diarrhea. So if you're constipated, when should you worry? Well, you should worry or certainly observe and be aware that if you have a change in bowel movements that persist, so they don't go away. You've added more fruit and veggie to your diet. You've started exercising a bit more. You've drunk a little bit more water. You've made sure you're taking Panados instead of Microdol. All of those things. If these bowel movements, if that change continues and you're now not passing any stool or gas, if you've got tummy ache, that really sore belly ache that goes on and on and on, and it is difficult to relieve unless you're able to pass some winds, severe cramping, if you start to feel nauseous and then you start vomiting, those are all signs that this may not just be constipation, and it shouldn't be ignored. You need then to contact your GP or, maybe speak to your stomach care nurse. I often have patients on my WhatsApp asking me, am I constipated? Do you think I'm constipated? What should I do? If you are not able to be in contact with anyone, try and think about what could be causing your constipation. Increase your fluid intake. Eat some fiber, bran, fruit, veggies. Fruit and veggies are actually the best things to eat if you are constipated. Bran, probably not so much if you're constipated, because unless you take sufficient fluid with that, it'll probably make you more constipated. Try some stewed fruit. If you've been sitting around reading, watching TV, maybe you've been at school lecture and attending lectures, so you've been sitting for long periods at a time, it might be an idea to get up and move. You can take a mild laxative if you have a colostomy. And I'm stating that if you have a colostomy, you can take a mild laxative, something like milk of magnesia, for instance. If the constipation persists, as I said earlier, you really need to seek medical help. So who would you contact? As I said earlier, contact a stomach care nurse, make an appointment to be seen. Very often, if you are severely constipated, the easiest and the quickest way for us to sort that out is to give you an enema. I don't want you giving yourselves an enema, but make an appointment to see your stomach care nurse, and she will do that for you. Or if you don't have a stomach care nurse or she's not available, see your GP, your surgeon, the person who actually created your stoma and did your operation. And as a last resort, go to the ER. But don't leave it. That's the point. Patients with ileostomies do not become constipated. And this is the difference. And so we're going to just talk a little bit about what to eat. And Dee is going to take you through that. And then we will talk about how to manage the complication.
Thanks, Jane. Okay, so just another quick recap from last month. What to eat if you have an ileostomy. So as a rule, ileostomies are difficult stomas to manage. They are constructed from the small intestine, and the stool or the poo that comes from an ileostomy is usually watery, sometimes with a bit of some bits in it. And what we want to try and achieve is that we get that stool to a mushy consistency. But it all depends on where in the small intestine your stoma is. So again, it depends on what your disease process was or is. It could be a Crohn's disease, or it could have been a small bowel cancer. We're not sure. And it depends on how much of your small intestine has been removed. That is going to determine what your stool consistency is. So once again, we can't put everybody who's got an ileostomy in one basket and say, ileostomates are all the same, you're all going to have the same stool consistency, you're all going to empty your bag X number of times a day, you're all only going to drain 1 liter in 24 hours, because that is not true. Some patients with an ileostomy might only drain up to 1 liter in 24 hours, and they might only need to empty their pouches 3 or 4 times a day and once at night. But other patients with an ileostomy might be draining 3 liters a day, and they might be having to empty their pouches way more often. And that also affects, and I'm just going to slip it in here, it is for a discussion at another meeting, but the type of stoma you have and where in this long tube of gastrointestinal tract your stoma is also affects how long your pouches can last for. So if you've got an ileostomy that's putting out less than 1 liter in 24 hours, and you've got the proper fitting pouch, it's probably going to last you a day or more longer than if you have an ileostomy that's higher up and pushing out 2 to 3 liters in 24 hours, because the seal is going to melt. So when we talk about ileostomy diet, and really those of you who do have an ileostomy, we strongly recommend that you sit down with your stomach care nurse or stomal therapist, or in the absence, your doctor, and really get the management of your diet and fluid intake for your ileostomy right. There's the do's and the don'ts. For an ileostomate, you should eat small regular meals. Sip and snack all through the day is really very advantageous. Eat foods that can help thicken the stool. So those are your starchy foods such as potato, rice, pasta, white bread. Bananas work really well at helping to thicken the stool. Peanut butter, avocado, boiled milk, bread, cheese. That's not to say that you can't have and shouldn't have your eggs, your meat, your fish, your chicken. Of course you should. But adding these foods into your diet in the 24-hour period will help to slow down the movement of that liquid stool through your ileostomy, and to help thicken the stool up as well. And medications such as Lomotil, Imodium, Fibrogen, or Smecta can be used, but I urge you not to take any of these without guidance from either your stomach care nurse or your doctor, and certainly not to take any of these as a recommendation from a fellow patient or ostomate. Do avoid drinking large amounts of fluid, particularly water. Water for an ileostomate, too much water for an ileostomate can actually cause dehydration and depletion of your salt and your other electrolytes that you need to keep healthy and to keep hydrated. Avoid eating and drinking at the same time. Cut down on sugary drinks and foods. And be careful of seeds, pips, nuts, dried fruit, thick greens. So in other words, like your bok choy greens and other thick leafy vegetables, lentils, mushrooms, grape skins and other skins. They can cause a bolus obstruction. Okay, so I'm going to hand over to Jane again, who's going to talk about ileostomy blockages, which is completely different to constipation. and an ileostomate really will not become constipated, and it's unlikely that a colostomate would get a food blockage. So it's two different things that we are talking about.
Who will possibly get a blockage? So we generally refer to a blockage in an ileostomy as a bolus obstruction, because it is nearly always as a consequence of a particular food or group of foods that you may have eaten. Not to say that there aren't other reasons why you may develop a blockage. So who would be that person? Someone who has an ileostomy. Possible causes would be food, as in a bolus obstruction, and then adhesions, which are the scar tissues that form inside of the abdomen. In an ileostomy, what can sometimes happen is the small intestine can twist around. That is often a consequence of an adhesion. And if you think about that cold bowl of spaghetti and how many loops of that spaghetti are all stuck together, and if one moves, they all move, that's what could contribute to a twisting of the small intestine. And then, of course, disease process. Crohn's disease, there could be a cancer, there could be a TB bowel. So the disease process is something that would contribute towards a blockage in an ileostomy. So how would you feel? And if any one of you with an ileostomy on tonight's Zoom call would know exactly what you feel. You're uncomfortable, very uncomfortable. You're bloated, pain, you've got lots of tummy cramps. You're passing sometimes a lot of wind. You're seeing less stool come into the bag. Often we'll get a call and say, nothing has happened. I changed my bag this morning, and since I changed my bag, nothing has gone into the bag. Have I done something wrong? It's not about changing your pouch. It's about what you have eaten in the last 24 hours. In some severe cases, you may be nauseous. This could lead to vomiting. Very often the stoma will swell because the bolus obstruction, this obstruction of food, is sitting right at the skin level and can't come through the skin level and through the stoma, and that causes the stoma to swell. Very often that too will cause pain around the stoma. Now, there should be no sensation on that stoma, and there should be no pain around the skin around your stoma. So these are all things that you may start to feel if you were to develop a blockage or a bolus obstruction.
So just to reiterate, if you have a colostomy and you don't pass stool every day into your bag, that can be pretty normal, okay? But when you have an ileostomy, you need to be passing stool into your pouch all the time.
Yeah.
So if you are not getting stool into your ileostomy pouch, immediately a little red flag should flick up.
So normal emptying of a pouch for someone with an ileostomy established would be between 4 and 6 times in 24 hours. So if you're not emptying your pouch at all, there's a problem. So what do? The first thing you would do is just to think about what you may have eaten in the last 24 hours. So if you've eaten something different, so perhaps you've had a mushroom pizza, or you decided that the lovely sweet mealies in Woolworths looked amazing and you just had to have them. Those are two things that are what we call insoluble fibers. So an insoluble fiber is a fiber that absorbs water. So it's an amazing thing because it will thicken. The problem is in a bolus obstruction with someone who has an ileostomy, is that the thick bits of fiber and stool cannot come through that little skin opening that was made when your stoma was created. And that's what causes the blockage. So the fiber inside of the intestine is not the problem. It's the problem of the fiber trying to come through the opening, through your ileostomy. So think about what you may have eaten. Stop eating and take fluids only. Try sitting in a warm bath. Massage your tummy around the stoma. The one thing you do not do is take a laxative. And if you are in severe pain and if you are vomiting, contact your stomach care nurse or go to your nearest ER. So how can you prevent blockages? Well, avoid the high fiber foods, avoid the mealies and the nuts and the dried fruit and the thick sausages and the lentils, the mushrooms, the mangoes. So some mangoes are fine and some mangoes are not. So unless you are able to tell which mango is okay and which mango isn't, rather avoid them. Skins on grapes, big thick skins on a baked potato, for instance, not a good thing for someone with an ileostomy to eat. So chew your food really well. Drink adequate fluids, but remember to keep your fluid intake, maintaining hydration, and keeping the output as thick as possible. So these are things that we need to consider.
They need to work out.
Yeah, that you need to work out with your stoma nurse. So if it is not a food blockage, there's nothing you can do. Obviously, you need to get to an emergency room. You need to contact a stomach care nurse. You need to contact your surgeon. So try and prevent blockages. I don't think there's an ileostomist probably that will go her life or his lifetime without a bolus obstruction at some point. It's very uncomfortable, but it is not something that is, it's just like having the worst tummy ache in the world. And until that blockage clears, you are going to be uncomfortable and you probably won't eat the orange again, and you probably won't sit and eat the bag of popcorn or nuts or whatever it was that you ate in the last 24 hours. You probably won't do that again. But it has to be managed. Try not to panic. If you can, if you're not feeling nauseous and if you're not vomiting, just stop eating food, just go on to a nice liquid diet, have a nice warm shower, get into a nice hot bath, massage your tummy, phone your stomach care nurse. She'll probably give you some more helpful tips. And, you know, it is possible that you may have to spend 24 hours in hospital while we irrigate and unblock you. But it's not, there's nothing sinister or malignant about it. It's a food blockage, which a patient with a colostomy will not get. They don't get food blockages. Yeah. So flatus, wind, farts, we all pass wind, all of us, every single last one of us. And you would be surprised to know that we can manufacture 3 liters per day. I've heard that it can even be more than that. And it's part of our gut health. The bacteria in our gut is what contributes to the methane and creates the gas. So even if you stop eating, you're going to pass at least 3 liters of flatus a day. And the reason that people with stomas always feel that they pass more wind than anyone else is that you're able to measure it in a sense. Because before you would pass that wind just into the atmosphere. Nobody has any idea of how much wind we pass. And a lot of it is swallowed air. So Dee and I sitting here tonight talking, will do a lot of farting in the next 24 hours because we would have taken in a lot of air as we were talking and swallowing.
Yeah. Okay, so Laratu, we had a question about pancaking. Please give input. All right, I saw all the communications on the WhatsApp group this morning about pancaking, and the some of the advice given regarding the pancaking was actually correct. So pancaking occurs when the stool, and it usually occurs with a colostomy because the stool is firm, it's thicker, it's sticky. And what happens is as the stool comes out of the stoma, if there's no space for the stool to fall down into the bag, it sticks up at the top. Now, the main reason for pancaking occurring is because there is no air in the pouch. Now, it could be that there's no air in the pouch because when the pouch has been emptied, patients very often make their pouches flat as possible so that they're not visible. So that's one reason. The other reason is that the filter on the pouch could be very effective and is taking all of the air out of the pouch. Or it could mean that you have a bit of an air leak. So in other words, the seal around your stoma is not completely sealed. And so any air coming into the bag is escaping underneath the seal, in which case you probably should be getting a little bit of an odor as well. So the way to manage pancaking is always keep a puff of air in your bag. So always separate the two sides, the front and the back of the pouch. And I do think that we're actually doing a session on pancaking in a couple of months, in which case we will have a pouch and we can demonstrate how you get air into the bag. But keeping a little bit of air in the bag is one thing to do. And the other is to lubricate the inside of the bag, the inside of the pouch, using a lubricant that your stomach care nurse can prescribe for you or arrange for you. So you put a couple of drops of the lubricating fluid inside the bag, and that in conjunction with having a bit of air in the bag should help the stool come out of the stoma and slip down into the bag. Yeah, so I think, you know, Faisal, again, one needs to get to the bottom of why somebody is becoming constipated. But certainly, you know, you can be irrigating, and the irrigation water only goes a certain distance along the colon, and then you might still be constipated behind that. Okay. But if constipation is an ongoing problem, it probably could be a solution. But I think it's always important to try and figure out what the constipation, what is causing the constipation.
Perfect. Thank you.
Yeah.